Why they are accumulated? Due to the renal failure, or kidney can't acidify the urine. So either there is acidification defect or there is the accumulation of the acids due to renal failure. Elimination of acids. There are two types of the acid which are eliminated by lungs and kidney. Volatile acids, eliminations of these acids by lungs, and non-volatile acids, they are eliminated by kidneys. So volatile acids which are eliminated from the lungs, like carbonic acid, non-volatile acid from the kidneys, lactic acid, phosphoric acid, acetoacetic acid, beta hydroxybutyric acid, or sulfuric acid. So these are the acids which are eliminated via kidneys. So kidney has got important role regarding the correction of the acidosis via reabsorption of the bicarbonate in the proximal nephron or generation of the bicarbonate in the distal nephron. So there are two methods by which kidney play role for the correction of the acidosis: reabsorption of the bicarbonate from the proximal nephron and generation of the bicarbonate by distal nephron. So in nephron, in the proximal tubular portion, reabsorption of the bicarbonate takes place and ammonia synthesis. Loop of Henle reabsorb ammonia, and the collecting duct secretion of the hydrogen ion and generation of the new bicarbonate. So these are the sites of the nephron in which the reabsorption takes place and secretion of the hydrogen ion. These contribute to correction of the acidosis. Now coming to the classification of metabolic acidosis, it is divided either hypercaloremic normal gap acidosis, that is mainly renal origin, or extra-renal origin. If it is renal origin, that is called proximal renal tubular acidosis, or in other words, it is called type 2 RTA. So type 2 RTA is the proximal and type 1 is the distal RTA. Hypercaloremic distal RTA is the type 4, or in other words, it is called hyporeninemic hypoaldosteronism. Renal tubular acidosis of renal insufficiency when GF are usually more than 15 to 20 ml per minute. So these are the causes of renal types of in the renal origin. Extrarenal origin means the cause is beyond the kidney due to diarrhea or gastrointestinal or urethral connection fistulas, or extrarenal losses from the pancreas or biliary secretion that leads to acidosis. Then anion gap metabolic acidosis, either renal origin again or extrarenal. Uremic acidosis, again GFR between usually less than 15 to 20. Extrarenal origin in which anion gap metabolic acidosis takes place. The common causes are lactic acidosis, diabetic ketoacidosis, alcoholic poisoning, starvation, or poisoning due to ethylene glycol, methanol, or aspirin salicylate. So these are the different causes of the extrarenal acidosis. So coming to the this slide shows the high anion gap and non-normal anion gap. High anion gap either due to increased production of the acids and or decreased elimination. Normal anion gap, renal or non-renal. So normal anion gap acidosis either due to hyperchloremia, in which chloride level is increased, or due to low bicarbonate or low to high potassium. Sometimes potassium is low or normal or high. It's depend upon which type of the acidosis. Now coming to the hyperchloremic metabolic acidosis, the common causes in which hyperchloremic metabolic acidosis takes place is the fluid loss due to diarrhea or from the ileostomy or ureterointestinal anastomosis. यूरेटर और इंटेस्टाइनल का अगर एनास्टोमोसिस करें, पैनक्रियाटिक, बिलरी, अपर इंटेस्टाइनल ड्रेनेज और फिस्टुलास that leads to the hyperchloremic metabolic acidosis. There are some drugs that leads to bicarbonate binding like cholestyramine and calcium chloride. So this slide shows the types of the renal tubular acidosis. Basically there are three types: type 1, type 2, type 4. Type 3 is hidden or overlapping. So type 1, in type 1, inability to excrete acid into the urine, and in type 2, inability to reabsorb bicarbonate. So difference between two is, in type 1, inability to excrete acid into the urine, and in type 2, inability to reabsorb the bicarbonate from the urine. So too much bicarbonate is excreted. In type 4, deficiency of or inability to respond to aldosterone. Already said that it is also called hyporeninemic hypoaldosteronism. Type 4 RTA commonly takes place in the diabetic patients or patients who are using the NSAID. So here is the deficiency or inability to respond to aldosterone hormones that cause the regulation of the potassium and sodium and excretion by the kidney. So basically three types: type 1, 2 and 4. So non-uremic defect in renal acidification takes place in case of RTA. Classification based on which site is involved: proximal tubular acidosis or DRTA, distal renal tubular acidosis, or is associated with the potassium, because in case of the type 4 usually potassium is high. So type 2 or proximal renal tubular acidosis, in which impaired reabsorption of the filtered bicarbonate takes place. So where is the defect? That is poorly understood, but sodium hydrogen exchanger of luminal membrane, here is the problem, and sodium potassium ATPase in the basolateral membrane, and defect in the carbonic anhydrase activity. In this type 2 RTA, urinary potassium wasting is common. If you check the spot urinary potassium, that will be high. Potassium excretion is common in case of type 2 RTA. What are the common causes of the proximal acidosis? That are divided into either isolated bicarbonate wasting, either idiopathic, cause is unknown, or secondary causes in which enzyme deficiency, carbonic anhydrase deficiency, or if you use the acetozolamide drug, that leads also this proximal RTA. Multiple dysfunction of proximal tubule due to hereditary systemic disorders or chronic hypocalcemia and secondary hyperparathyroidism. There are some drugs, heavy metals, especially aminoglycoside group, gentamicin, tobramycin, paraperitonemia, renal transplant rejections, and sometime in glomerular disease or in the secondary nephrotic syndrome, in which their deposition of the amyloid takes place, that leads to also the proximal renal tubular acidosis. So what are the main features of the proximal renal tubular acidosis? Usually chronic stable acidosis. In this condition, bicarb usually between 15 to 20 milliequivalent per liter. Normally normal value is 25 milliequivalent per liter. If you check the urinary pH, that will be less than 5.5 during acidosis. So this is the characteristic feature. First of all, always check the urinary pH. If it is less than 5.5, so major cause is the proximal RTA. And fractional bicarbonate excretion more than 15. Other tubular defect that leads to proximal site present are urine glucosuria or amino aciduria, phosphaturia, and uricosuriا takes place in case of the proximal problem, because major portion of these glucose or amino acids and these the reabsorption takes place in the proximal tubule. But if there is the defect here, then they will excrete it in the urine. So stone formation is rare in this condition. Bone disease is also common. Now coming to the distal acidification defect. Distal defect with normal or low potassium. Type 1 distal is called type 1 or classical, that is called classical renal tubular acidosis. Okay. And distal defect with hyperkalemia, that is called type 4 hyperkalemic renal tubular acidosis, type 4 RTA. Sorry. Type 1 renal tubular acidosis, decreased net hydrogen ion secretion, or here is the problem with hydrogen ATPase pump secretory defect, or abnormal back leak of hydrogen from the lumen into cell permeable defect. So what are the causes or etiology of the type 1 distal RTA? Primary and hereditary systemic disorders, hypercalciuria, so that leads to also nephrocalcinosis. That is the reason stone formation is common in these autoimmune diseases, lupus, and other connective tissue disorders. Drugs, amphotericin B, toluene, analgesic abuse, that leads to type 1 RTA. Now what are the main features of the hypokalemic DRTA? These patients can present with severe acidosis. Okay, and urine pH in acidosis more than 5.5. But if you remember, in the proximal RTA, the urinary pH is less than 5.5. So here nephrocalcinosis takes place, that leads to stone formation, and hypercalciuria and hypocytinuria occur. Distal acidosis with hyperkalemia, that is called type 4 RTA. Here is the aldosterone deficiency or resistant rate dependent defect. It is unrelated to aldosterone voltage dependent defect, in which hyperkalemia takes place. So hyperkalemic renal tubular acidosis, it is the most common type of tubular disorders. It has got complex pathophysiology, either decreased hydrogen pump activity or decreased sodium reabsorption, or it is associated with the hyperkalemia mediated suppression of aminogenesis. In this condition, acidosis is rarely severe. So what are the causes of the type 4 RTA? Main cause is mineralocorticoid deficiency. That is the reason it is called hyporeninemic hypoaldosteronism. The causes of the mineralocorticoid deficiency either combined with the glucocorticoid deficiency or isolated mineralocorticoid deficiency, or low renin state in case of diabetes, non-steroidal anti-inflammatory drugs RTA and tubulointerstitial disorders, or the patients which are using the angiotensin converting enzyme inhibitors. Mineralocorticoid resistance, either because problem here is due to mineralocorticoid aldosterone, either deficiency or due to resistance. Deficiency, discuss with you. Now resistance due to with salt wasting, in case in childhood forms, or medullary destruction or problem in the medulla, or if the drugs spironolactone usage without salt wasting cyclosporin, that this drug usually called calcineurin inhibitors, which is used, it is immunosuppressive drugs. It's commonly used in renal transplant or the nephrotic syndrome, which are non-responder to the steroids. So other causes unrelated to aldosterone, means apart from aldosterone, the drugs like amiloride, trimetrine, these are the diuretics, or case of obstructive nephropathy, sickle cell disease, or inadequate sodium delivery to distal nephron. So this is the diagrammatic picture that tell us the importance of the urine pH in case of the type 4 renal tubular acidosis. So urinary pH in type 4 renal tubular acidosis, net acid excretion is always decreased. However, the urinary pH can be variable in structural disease of the kidney. The problem is the predominant defect is decreased distal hydrogen ion secretion. So, see the top, type 4 RTA, either decrease distal hydrogen ion secretion, then urinary pH is more than 5.5 and net acid excretion decrease. If there is decreased potassium secretion, then raised plasma potassium level and decrease ammonia and ammonium synthesis, in which if you check the urinary pH, it should be less than 5.5. So this picture shows the what is the pathophysiology of the type 4 RTA. So common causes of the type 4 RTA already discussed in the previous slides. This is the again repetition of that. So it's not necessary to discuss again. You can review this slide. So this slide shows what are the factors that differentiate in the type 1 and type 4 RTA. In case of type 1 RTA, check the serum potassium, that will be low. But in case of type 4 RTA, either high, normal or high. High to normal or high. But it is important, it is hypokalemia in case of type 1 RTA, but type 4 always normal to high, higher side. Renal function should be normal or near normal in case of type 1 RTA, but in case of the type 4, renal function should be disturbed, CKD 3, 4 or 5, chronic kidney disease. So when creatinine clearance is decreased, these patients can develop type 4 RTA. So we should always check the urinary pH during acidosis. That will be 6 to 6.5 in case of type 1 RTA, but it is acidic in type 4 RTA 5.5. And if you check the serum Bicop, that will be low in case of type 1 RTA, 10 to 20 milliequivalent per liter, but in case of the type 4 RTA, 16 to 22 milliequivalent per liter. Now what are the investigation that will be done that in case of renal tubular acidosis? Already discussed, urinary pH has got vital role in the investigation that will differentiate either type 1, type 2 or type 4 RTA. Normal urine pH 4.5 to 8, ideally 6.5 to 7.5. Urine net charge means sodium plus potassium minus chloride, that is called urine net charge. Fractional bicarbonate excretion, urinary bicarb PCO2, it should be more than 70, and ammonium chloride loading test. So urine pH, it represents the free hydrogen ion in the urine. Ion does not tell about the total acid excretion. Ammonium phosphate may be excreted and should be acidic in chronic acidosis. The pH should be less than 5.5. The method, either collection, testing or interpretations, these are the methods by which we can check the urinary pH and test for urinary ammonium excretion, urinary anion gap minus urine net charge. Urinary anion gap, it is the sum of the sodium, potassium, means cation, and sodium, potassium, calcium, magnesium and ammonium. So negative value implies the ammonium excretion more than 80. And positive value implies the impaired ammonium excretion. If it is written urinary ammonium excretion, ammonium chloride test is It is positive, that shows the impaired ammonium excretion. So hyperchloremic acidosis with normal or low potassium. Urine pH during acidosis is important. If it is less than 5.5, either GI loss or proximal renal tubular acidosis. Proximal RTA or DRTA pH may be 5.5. Urinary pH during acidosis, if it is less than 5.5, we should check plasma aldosterone. If it is normal or high, it is that indicate aldosterone resistant. If it is low, we should check the plasma cortisol, either low or normal. But if the pH is more than 5.5, that is not related to aldosterone. So this slide is very important. That shows the assessment of the patient with renal tubular acidosis. This slide taken from the comprehensive book of the nephrology. So first, renal tubular acidosis on the top, RTA. Always we should assess proximal tubular dysfunction, proximal tubular function normal, if it is normal, or abnormal. If it is normal, measure plasma potassium level. If it is hyperkalemia, potassium is high, so we should must think this is the type 4 RTA. If the potassium is normal or below the normal, normokalemia or hypokalemia, then we should measure urinary pH and the plasma potassium level. If the plasma potassium less than 3.5, urinary pH more than 5.5, and hypokalemia, that is the distal RTA, type 1 RTA. So this is the differentiating point. If the plasma potassium 3.5 to 5 and urinary pH is less than 5.5, so this is the renal tubular acidosis of the renal insufficiency. Okay. So this is the last slide that will differentiate between the three disorders, acid-base disorders, renal tubular disorders, type 2, type 1 and type 4. So there is the importance of urinary pH, plasma potassium, and the association of the certain diseases, and fraction excretion of the bicarb. Okay, first check the plasma potassium. It is low in case of type 2 renal tubular acidosis, and it is low to normal in case of type 1, but always high in case of hyperkalemia and in hyporeninemic hypoaldosteronism, that is called type 4 RTA. Urinary pH is important. If it is less than 5.5, so must think the type 2. In type 1, it is more than 5.5. But in type 4, again pH it should be less than 5.5. Urine changes always present in the three disorders. They are associated type 2 just like Fanconi, and type 1 with nephrocalcinosis, stone formation, and type 4 in case of the renal insufficiency, CKD or low GFR. If you check the fractional excretion of the bicarbonate, in case of type 2, it should be more than 10 to 15%. Nephrocalcinosis in type 1 less than 5%. and in case of type 4, 5 to 10%. They respond type 2 least readily, but type 1 the quick response, and type 4 is also less responsive. So this is all about regarding the renal tubular acidosis. What is acidosis? How to approach the renal tubular acidosis? What are the common conditions that lead to this acidosis, and what are the consequences of this? How to differentiate in the various acidosis type 1, type 2 and type 4 renal tubular acidosis. So thank you very much. This is all about the renal tubular acidosis.